it has been seen that at least more than 50% babies might fail in CPAP or SFSC. So next slide, please. Next slide. Next slide, Anando. So how many of you are currently use non-invasive ventilation unit? Please write in the chat box. Please write. And I'm sure many of you are using non-invasive ventilation unit. And how many of you are currently use non-invasive routinely, occasionally, or rely on invasive ventilation? Please write in the chat box. One, yes, routinely. Prashanjit is also writing routinely. Good. Shukla is writing occasionally. I think I am sure that as I have seen from all of you, most of you are using it routinely. The next slide, please. So, which modality of non-invasive ventilation is most commonly used at your unit? Please write in the chat box. I'll wait for a few seconds. NI, you are using 3. That means SFNC. Most of you are using CPAP. Good. CPAP. CPAP. Prashanjit, they are writing CPAP. Okay. Next. Busra CPAP. Madhurima CPAP 2. NSWB. Shruti CPAP. Arsalan 3. So what I have seen from the from you, all of you, that most of you are using CPAP, but few are using NIPPB. Good. Next slide. So based on your experience, how often do you think that CPAP failure in preterm infants despite surfactant therapy? Please write in the chat box. Showman is saying sometimes. Anshu saying very rarely. Good. Dev Kumar 2 sometimes. Shruti says sometimes. Rajkumar says 1. Devbendu says 1 very rarely. That means what I have seen from all of you, that most of you are comfortable with CPAP, but sometimes CPAP might fail. So if there is a failure of CPAP, there sometimes even it's a rarely, just tell me, you can write which group of infants will fail CPAP, TARP or preterm. Just write T or P in the chat box. P. Yes. 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 So what we have seen, that all of you agree that many a times preterm babies will fail CPAP. So let us see what is the incidence of failure of CPAP amongst the preterm infants. Arindo, can you share this next slide? So CPAP, although is the standard of care, what all of you have said, but studies have shown, especially preterm infants less than 28 weeks or less than 30 weeks, CPAP failure may go up to 50% of the infants. So you are very right. Preterm infants, those who are born less than 28 weeks or less than 32 weeks, CPAP failure may go to up to 50%. So in this 50% of the infants, if you do not have any other non-invasive support, definitely will go to invasive kind of respiratory support. That is invasive mechanical ventilation. Next slide, please. So what we have seen, this is non-invasive positive pressure ventilation. And we need more effective non-invasive positive pressure methods other than CPAP. That means when a baby fails to CPAP, immediately do not jump to invasive mechanical ventilation. If you have got the facility for non-invasive positive pressure ventilation, you can start non-invasive positive pressure ventilation. That means NIPP is a bridge between CPAP and invasive mechanical ventilation. Next slide. So what are the different types of non-invasive support? I'm sure yesterday Orithra has already told you. It may be continuous positive pressure like CPAP or high flow nasal cannula. I am not going to in detail. In CPAP or high flow nasal cannula, what we have seen, there is a constant flow of gas during both inspiration and expiration. And there are some variable type of CPAP. But in variable type of CPAP pressure, there may be non-invasive positive pressure ventilation, synchronous non um, in NIPPV, and nasal high frequency oscillation ventilation, and nasal BiPAP. So today, what I am going to speak: non-invasive positive pressure ventilation, or NIPPV, synchronous or non-synchronous nasal high frequency oscillation ventilation, NAVA, and BiPAP. Next slide. So what I have already told you, NIPP is the bridge between CPAP and NIP, IMP. Next, next. So NIPPV, nasal high frequency oxygen ventilation, is the bridge between CPAP and invasive ventilation. So what is NIPPV? Let us see. Next slide, please. So what is NIPP does? It is said that it helps in the patency of upper airway control during inspiration. So what happens when the diaphragm flattens? It generates a negative pressure. So because of negative pressure, there may be airway may be collapse. This collapse is prevented by three stimulus simultaneously. One is opening of the glottis, stimulation of the pharyngeal pressure receptor by negative pressure, reflex activation of upper airway abductor muscle that stiffen and widen the pharynx, and genioglossus and geniohyoid. That means when a baby in a spontaneous breathing infant, when a baby takes a spontaneous breath, the baby will create a negative interpleural pressure. And because of negative interpleural pressure, there is always a natural tendency for the alveoli to collapse. But this collapse is prevented by these three simultaneous events like opening of the glottis, stimulation of the pharyngeal pressure receptor by negative pressure, and also stiffening of the abductor group of muscles to keep the airway patent. Next slide. So identify the ventilation modality in this. In the A, just write what you are seeing A and B, which is CPAP and which is NIPPV. Just write in the chat box. Please write in the chat box. A CPAP, very good. Next, A CPAP. My rheumator is also telling B NIV. From still B NIPV. Kazim is saying CPAP. A B, you are right. Next, Rasmus telling the truth. A CPAP, next be a NIP. So what you see in A, there is a constant pressure delivered both during inspiration and expiration. But in the B, what we have seen, on the top of CPAP, there is some inflation. That is peak inspiratory pressure or peak inflammatory pressure. That means when you are providing NIPBB, on the top of CPAP, you are providing some kind of inflation. Once you are providing some inflation, it definitely increases the mean area pressure. That means what we have seen from this graph, if you use NIPPB, it will give one inflation pressure, that is PIP, and also it will increase the mean area pressure. And all we have heard from the first lecture, if you want to improve oxygenation, the mean area pressure should you have to operate on mean area pressure. Second important thing, in our mechanical ventilation or whatever ventilation we do, we have got two purposes. One is you have to open the alveoli and you have to keep the alveoli open. What we have seen, this PIP helps in the opening of the alveoli, and this PWP helps to keep the alveoli open. So the mood mantra of any ventilation is you have to open the alveoli and keep it open. If you use NIPPV, you can have both the purpose served. Next slide, please. So what I have already told you, in NIPV there is continuous end expiratory pressure, and on the top of that there is an intermittent higher pressure, that is PIP. Many people argue if I increase the CPAP pressure, it may be equivalent to NIPV. That is not exactly true. Why? If you give 12 or 15 centimeter pressure, this 12 and 15 centimeter pressure will be delivered both during inspiration and expiration. But in case of NIPV, it will be 5 or 6, and on the top of that there will be intermittent higher pressure, and that will be intermittent. That will not be continuous. And you will all agree with me. If you give 12 or 15 centimeter CPAP pressure, definitely it is going to cause some harm to the baby. In that way, NIPV will be better than CPAP. Next slide, please. So, what we have learned in NIPV on the top of CPAP there is some inflation. So, this can be of two types. One is non-synchronous NIPV and another is synchronous NIPV. We'll discuss one by one. Next slide, please. Next slide, Mindu. The next slide, please. Next slide.
On in the next slide.
Ah. So, next slide. So, I think all of you are now by this time you are aware of synchronization. Just tell me, do you think synchronization is possible in nasal intermittent positive pressure ventilation? One, yes, synchronization is possible. Two, no, synchronization is not possible. Three, not sure. You are saying yes. Showmin is also saying yes. Bushra is also saying yes. Next, anyone? Raskumar is saying yes. Okay. Everybody is on the opinion that synchronization is possible. Madhurima is telling the 80% of the cases. Next. So all of you agree that synchronization is possible, but it is not that simple. Because when you are using non-invasive positive pressure ventilation, you are using interface as a mask or prong. When you are using mask and prong, it is not very easy to prevent the leak. Because in infants or newborn, when you use CPAP or NIPV, any interface use either on nasal prong or nasal mask, there will be some amount of leak. With so much of leak, it is not very easy to keep synchronization possible. Next slide, please. Next, previous slide. So, if the synchronization is not possible, what happens? So, you see, these are the spontaneous breath. The spontaneous breath, next, just click. So, if you see, these are all ventilator breaths. If you can see the first breath, when the baby was in the inspirating phase, that time expiration has started. So when the in the second slide, when the baby was in expirating, then there was an inspiration of the ventilator. In the third breath, you see when the baby was in the exhalation phase, ventilator was in the inspiratory phase. In the last slide, next, next. So you see, just go to the previous slide. Go to the previous slide. So if you can see here, most of the breath are non-synchronous. Only one breath is synchronous. So studies have seen that if we use non-synchronous NIBBB, only 25 or 30% of the breath can be synchronized. Next slide. Next. So most of the breaths are not synchronous with the infant. Only 25 to 30% breath synchronized. That synchronization occurs by chance. Next. So this is whatever machines we are using in our clinical practice, most of the units are non-synchronous. That means they are giving non-synchronization breath, but only 25 or 50, maximum 30% breath may be synchronized by chance. What do you mean by synchronization? Next slide, please. Next slide. So synchronized means once you once the baby is taking inspiration, ventilator will be on the inspiration phase. When the baby is in the expiration phase, medicine will also in the expiration phase. But what will happen if the baby in the breaths are not synchronized? So when the ventilator is delivering a breath, glottis should open. Suppose glottis is open and the glottis is still open and the next breath is due. Before the baby patient can go for the exhalation, there is another breath from the machine. So the second mechanical breath occurred immediately after the end of the spontaneous expiration, forcing a forced expiration altering the infant's respiratory rhythm. That means what might happen? Suppose baby has closed the body and ventilator is delivering a breath. So, what will happen to this breath? This breath will go to the stomach. Or suppose patient is not ready for exhalation, ventilator is delivering a breath on that. So when the alveoli is already inflated, if ventilator is delivering a breath during that time, so what will happen? So patient will have a forced expiration that is called a varying breath reflex. So it will be induction of forced expiration and release of next inspiration. So what might happen? Ventilator is pushing and baby is closing the glottis. So what might happen? One thing might happen, the most of the breath will go to the stomach. Second thing might happen, ventilator is pushing breath, baby is still in the inspiration phase, and when the baby is trying to exhale, again there is a breath from the ventilator. So there will be over inflation of the lung. When there is over inflation of the lung, there will be forced expiration. Next slide. So this is what has been shown. Next slide, please. So that is what I have shown. Active pharyngeal closure against intermittent positive pressure ventilation, which can mimic lung ventilation. Next slide. So asynchronous breath, there is a discomfort to the baby. That means most of the breaths will be asynchronous. This may be associated with high failure rate. That is in most cases to patient discomfort. Asynchrony during NIPV, most important cause of discomfort and frequent reason for NIP failure. Only synchronization may be possible by NAVA. This we will discuss later on. Next slide. So I think these are the ways the triggering can be possible. So what techniques or device can be used to active synchronization in APV? Just write in the chat box. Flow triggering device, patient triggering device, neural integrated NAVA. Please write in the chat box. What do you think? All. Very good. Next. Musa is also writing all. Pani is telling all. Anshuling is telling all. Next. So let me ask you one question. You can write. Out of all triggering device, what do you think which will be the best in non-invasive positive pressure ventilation? Flow triggering device, pressure triggering device, or NAVA? Just write in the chat box. Which will be best? NAVA, NAVA. Anyone? NAVA, NAVA. Raskumari says flow triggering. 3 is best. So all of you agree that NAVA will be best, but there will be a problem in the flow triggering device and pressure triggering device. Thank you. All of you are correct. Next slide, please. So why do you think that these are challenging in synchronization in ABB? Appropriate triggering device, leak or others? Write in the chat box. Leak. Very good. Leak. I've given you the answer actually before that. I'm sure it's very good. That's what is saying. It is the yes. Also saying that it is leak. So you all of you are correct because when you are using non-invasive positive pressure ventilation, either you can use a mask or prong and mouth will be open. So most of the time there will be a lot of leak. With so much of leak, it is not possible to actually synchronize patient's breath by any flow sensor. Next slide, please. So can you answer which will be better, flow sensor or pressure trigger? You can write F or P out of these two because Nava is not always available. Shomini says flow, 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 flow. I think you are correct that if you use flow sensor, the workload breathing will be less. But there are some inherent problem of flow sensor in case of non-invasive positive pressure ventilation. So we'll discuss. So the triggering device, those synchronized or non-invasive positive pressure ventilation is abdominal capsule or breast capsule, pressure trigger device, flow trigger device, and NAVA device. Next, next slide, please. So one is abdominal capsule. What is abdominal capsule? It is just like your radiodermal probe. It's a balloon which is inflated and it is connected to the pressure transducer. And because of the abdominal movement, the ventilator will recognize that it is a breath. But the problem of this device is that it may show some artifact because if there is a hiccup or some cough or some seizure, it may so there will be a lot of artifact. So one is abdominal capsule, and this abdominal capsule was marketed by one ventilator, that is the infrastructure ventilator. That is no more marketed nowadays. So abdominal capsule, there may be immediate triggering, maybe is possible, but the problem is there will be too many artifacts. Next slide. Then the pressure trigger. Pressure trigger means, and one important thing you should remember. I think yesterday Aditya was also training, also told to all of you, whenever you use some non-invasive positive pressure ventilation, two criteria should be fulfilled. One is patient should be hemodynamically stable, and patient should have spontaneous breathing effort. So, if any patient who is not spontaneously breathing or the baby is not hemodynamically stable, you cannot use any kind of non-invasive positive pressure ventilation. So, in the pressure trigger, what happens? Baby has to create a negative pressure, and all of you will agree with me, in a small preterm infant, the baby may not have that much of negative pressure to create to sense a breath. So that is the problem of pressure trigger, because we know that from our first lecture we have known most of the babies may create minus 6 centimeter water pressure. So if the baby can create that much of minus 6 centimeter or minus 1 centimeter pressure, then only ventilator will recognize the breath and ventilator will deliver the breath. So that is the problem of pressure trigger, because most of the smallest preterm infant, they may not be able to produce that much of negative pressure from when they are connected with NIPPV. Same thing happens in the flow trigger, and also leak will also have a problem. In the flow trigger also, when the baby is, there is a constant flow of gas in the circuit that is known as bias flow. So what happened? So when there is a bias flow, and there should be some change in the flow. But if that change in the flow may be misdiagnosed as a flow because of the leak. As I have already told you, in case of NIPB, there will be a lot of leaks with lot that much of leak and small preterm infant, the pressure trigger and fold trigger may not be possible. That is why it is seen in most of the ventilator, although they are claiming triggering, but in real life this is not possible. This is practically actually difficult. Next slide, please. Next slide. So there is another flow sensor that is called pneumotachograph. In pneumotachograph, what happens? This is this is also flow sensor, but it is not hot air anemometer. So the change, because of the change in the flow, there is some change in the pressure. That change in the pressure will be detected by the machine, and machine will then deliver a breath. And the ventilator discards the or the slow changing flow signal of the leak. So many ventilators, some ventilators they are using pneumotachograph. So even in pneumotachograph, what we have seen in our clinical practice, patient has to generate good amount of flow. Otherwise, this patient will also not be able to actually trigger breath. That is why what we have seen, the bigger infants may trigger breath, but the smallest infant will not be able to trigger a breath. Next slide, please. So what about NAVA? Because if so, these are the problems of what we have learned. One is if there is flow triggering, there will be lot of leak. In case of pressure triggering, patient will not be able to generate that much of pressure loss. In NAVA, what happens, because the electrical activity of diaphragm is detected by the machine, and machine will deliver a breath. So that is in this is very highly sensitive. But one of the problem is that it is little bit invasive, because a NAVA catheter is pushed, and one catheter cost is around 12,000 or 15,000 rupees, and this catheter size also differs in case of and machine deliver a breath. Next slide. And response time is around 35. So if there is synchronization, what will happen? Positive pressure will be transmitted efficiently to the lung, because it is delivered where the glottis is open. There will be increased transpulmonary pressure, and there will be thoracoabdominal synchrony, asynchrony will be reduced. Next slide. So there will be improved ventilation, decreased workout breathing, and increased comfort. Next. So what is thoracoabdominal synchrony? So what happens during a positive pressure ventilation? What happens? Patient creates a negative pressure, so alveoli will try to collapse. But in case of dark baby or older children, what happens? The chest wall compliance will be better. So alveoli will create a negative pressure, and this chest wall will try to stabilize, not to allow the chest wall to go in. So that way, thoracoabdominal synchrony is maintained in case of adult and older children. But in case of smaller infants, the chest wall compliance is low. So when the patient is taking a negative breath, airway will collapse. At the same time, chest wall will go in. So if it is a non-synchronous breath, then we complete asynchrony. Next slide. So I am not going to this phase angle means next slide please. This phase angle is zero when there is complete synchrony, and this phase angle is 180 degree when there is a asynchrony. So if you use NIPPB, that phase angle may be zero, so that the thoracoabdominal synchrony will be maintained. Next slide. Next slide. The same thing has been shown here. Next. So what is the physiological basis of benefits of NIPP? It increases FRC because we have told you it gives inflation pressure. It will improve alveolar recruitment because of an overall higher manual pressure. It will enhance lung compliance, reopen partially collapsed alveoli, greater thallium volume, reduce workout breathing, reduce thoracoabdominal motion asynchrony, and decrease airflow resistance reduction in the apneic episodes. Next slide, please. So what happens once you are giving positive pressure ventilation, there will be Hertz paradoxical reflex. It says it augments the inspiratory drive. What Hertz saw that if you give a inflation pressure, the inspiration time will increase. It will improve the inspiration. That way, it will decrease the central apnea. And because of the high pharyngeal pressure, that will activate our dilator muscles of the pharynx, and that will reduce obstructive apnea. And because of the high inspiratory flow, that is soft pellet will post against the tongue, so that will also reduce obstructive apnea. So because of the splinting of the airway, it will reduce the obstructive apnea, and because of Hertz paradoxical reflex, it will reduce the incidence of central apnea. Next slide. So CPAP can be NIPV can be used as a primary respiratory support like RDS, TTNB, mass pneumonia, and secondary mode as a post-extubation and apnea of prematurity. Next slide. Next slide. So what are the contraindication in unoperated diaphragmatic hernia? Next, nasal obstruction like coronal atresia, tracheoesophageal fistula, and immediate postoperative period like extravascular surgery. Next slide, please. It's evidence. So what this evidence says? Next slide. So now tell me, who is non-invasive modality would you use in your primary mode and secondary mode for neonatal respiratory support? Write in the chat box. You have found all the benefits of NIPV as well as CPAP. Yes, CPAP, okay. Next, to primary NIPV, primary CPAP, secondary NIPV. Next, it depends on the clinical scenario, okay. Next, so many says 1 and 2, okay. Next, primary CPAP, secondary NIPV, okay. So then is in depends on the primary says 2, okay. So let us see what the evidence says. Next slide, please. Which factor will okay? So it has been seen that NIV failure rate is around 5 to 25%. If you see the slide, red bar is showing nasal CPAP and green bar is showing NIPV. So it has been seen that failure rate in NIPV is around 5 to 25%. In our unit, our NIPV failure rate is around 10 to 11%. That means out of 100 babies, 90 babies will be successful both as a primary mode or a secondary mode. Next slide, please. And it has got effect on bronchopulmonary dysplasia. Next slide. So in the systematic review or meta-analysis, it has been said NIPP is better than SS7C, NIPP is better than as a CPAP, both as a primary mode as well as secondary mode. But there was no difference in the BPD, mortality or nasal trauma. Next slide. So if you see that the primary mode for respiratory RDS, there is 35% reduction in respiratory failure. Need for mechanical intrathecal intubation around 32% reduction. Need for developing CLD is around 30%. Next slide. So as a primary mode, it is better than CPAP. Next. As a secondary mode, also it has been seen that it is better than CPAP. So studies have shown that both as a primary mode and secondary mode, it is better than CPAP. Next. So synchronization used to deliver NLPV may be important, however, data are insufficient to support strong conclusion. So what evidence we have seen from this that NIPP is better than CPAP both as a primary mode or as a secondary mode. But the problem is that if you want to provide NIPP, you need a ventilator. A ventilator costs around 10 to 12 lakhs, but in 2 to 3 lakhs or 4 lakhs, you can get a CPAP. So with the cost of the one ventilator, you can buy 2 to 3 CPAP. So if you have got the facility for NIPP, what is that you can use NIPP as a both as a primary mode or as a secondary mode. Next slide. So now let us discuss practical application of nasal intermittent positive pressure ventilation. Next. So now tell me what is the biggest challenge faced with NIPV in your practice? Those who are using NIPV, synchronization use, nasal interface related complication, leak management, availability of specific ventilator or others, right? Availability of specific ventilator, good. Next. Anyone? Yes. Yes. Next. Any other? Please raise your hand. Anyone? Two, three, both synchronization, non nasal representative complication, leak management, others. Okay. So all of you have got problem of a ventilator in the unit. Even you have got the ventilator, you have got this nasal interface related complication, leak management, available specific ventilator. Now tell me, do you need a special ventilator for, to provide NIPV or whatever ventilator you have having, you can provide NIPV? Yes or no? Do you need a special ventilator or whatever ventilator you have, what you can use to provide NIPV? Tell, right? Yes or no? Do we need a special ventilator? Ventilator with NIV mode, good, very good. Any ventilator NIV mode? Yes, yes. Anyone? Yes. Next. Anyone? So next slide, please. So, but what is actually in clinical practice what to do? Any ventilator who has got an IMB mode or any mode you can use as a NIPV mode. So non-synchronous NIPV can be delivered any ventilator that can provide nasal CPAP or IMB mode. So we do not need a special ventilator. But one important point that if the software is not available, it will give lot of alarm. So you can use IMB mode of Babylog 8000 plus or any other ventilator. But if you use that ventilator, what will happen? That will provide some amount of pressure, but that will give a lot of noise. But synchronous NIB machine are not commonly available. Julia V3 neutral ventilator, Cummins, Sophie, SLA 6000, Optimatic, etc. So any ventilator which can provide nasal CPAP or any IMB mode or IPV mode that we can use for non-synchronous positive pressure ventilation. So you need a ventilator, but not necessarily you need a special ventilator. But yes, you need a ventilator when you buy a ventilator for non-synchronous positive pressure ventilation. You buy a ventilator with the software for providing this kind of support. Next slide. So out of all this synchronous ventilator, only FDA approved ventilator is infant stand ventilator in US. That is the reason in US clinicians are not using non-invasive positive pressure ventilation most of the times. They are using more higher CPAP pressure. Next slide, please. So these are the machine we use in our IPGMR. The first machine we have seen is Babylog 8000 plus. This is Servo N of Mackay. This is VN 600 of VN 600 Babylog. This is Fabian. Next slide, please. This machine is a newly Optimatics. This is marketed by one Indian company. It is not bad. It can give all NIPV, synchronous, non-synchronous, high flow, nasal high frequency, little bit, and CPAP. So all the modalities you may find in this machine. This is marketed by one of the company here. So what about Dagger? Dagger machine you can use. Even Babylog 8000 plus in my first slide. Next, can you go to the previous slide? Previous slide, previous. So this is Babylog 8000 plus. In Babylog 8000 plus, you go to the IMB mode, and that IMB mode you can use uh, to provide NIPV. Only thing is that when you are using NIPV without a tube, you are using mass, there will be lot, there will be pressure loss. In that case, in if you use Babylog 8000 plus, what you can do, you can keep the flow at the higher level, like 8 liter or 10 liters. So what we will find in the screen how much pressure is delivered and how much pressure you have set. If the ventilator is delivering the same pressure what you have said, that means your flow is adequate. So what we have to do in if you use Babylog 8000 plus or Dagger machine, where there is no automatic flow adjustment, you can manually adjust the flow based on the based on the pressure what you have said seen in the graphic. So how do you know that your flow is adequate? In the graphic, you will see whatever pressure you have set, the same pressure is delivered by the machine. That means your flow is adequate. Next slide. Next slide. So these are the whatever interfaces you use in CPAP, the same interface you use in can use nasal IPV. But in our NI SSCAM, we frequently use we are comfortable with nasal mask or RAM cannula. So next. So in the slide, switch on the video. Just click. Just click. So you see this machine actually this is synchronous NIV machine. This is Hamilton. So here they use pneumotachometer. Next slide, please. Next slide. Just switch on. Just see this baby is breathing, and you see there is some triangle. This triangle means these are all synchronous breath. But what we have seen in with Hamilton also, this Hamilton use the pneumotachometer is the flow sensor. But here we have if there is some condensation, you may get this triangle. So whenever you see this triangle, don't be sure that actually these waves are synchronized. If there is some condensation in the circuit, that will it will show like this. But this baby is little bit bigger baby, that's why he is synchronizing. So synchronization in our hospital, the machine we are having one is Hamilton and second is Optimatics. Next, next. See, here you have seen some blue bar and the some white bar. The blue bar means these are all synchronized. This machine, this is a low cost machine around 4 to 5 lakhs. What we have seen that 60 to 70% breath are synchronized. So these are all synchronized breaths. This is connected to a vein. Next slide, please. So this is another. This is servo oven ventilator. You have seen it is a pressure trigger. You have seen there is some changes in the color here. This change in the color means this is triggering pressure. This pressure trigger is only feasible if the baby is big. This is a bigger infant, that's why it is triggering all breath. But you may not find everything there. Another important thing, whenever you see the graphics, this is the pressure graphics, this is the flow, and this is the volume. Only in one important thing, if you see flow and volume, that means there is a flow sensor is there. If the flow sensor is there, not there, how to understand synchronize. So if the you see if there is no synchronization, this white line will not be there. That is the way. So in different ventilator, the different types of indicator is there. In some ventilator, there is change in the color. What I have shown you optimatics. There's a whole bar is blue. In some ventilator, there will be some change in the color. In this particular machine in servo, it will be white. If you find white color change in the pressure, that means baby is triggering pressure. If you see the white color change here, that means baby is triggering flow. I think is it clear? Yeah. Next slide, please. Next slide. So what happens if there is no triggering? So what will happen if the breath is not flow is not if the breath is not triggered? Suppose trigger means when the patient is taking respiration, same time ventilator is also delivering a breath. If it is it happens that there will be more talabulum will be delivered. But this is not possible. Flow signal in open circuit always affected by lead and increased by dead space if dead space. Next slide, please. So what are the things we have to say? We have to set the PIP. PIP set based on chest rise. PWP is just important. PIP you said based on the chest rise and the disease condition. PWP you said based on the retraction, intercostal diameter of the chest, and lung expansion in chest X-ray and saturation. Respiratory rate based on the preterm and term. In preterm you can use 50, in a term 50, term 40. FiO2 based on saturation. And the flow, if it is automatic flow adjustment device, then you don't have to adjust the flow. If it is not automatic adjustment device, then you have to set the flow manually, like in your Babylog 8000 plus. Next slide, please. So when you are using as a primary mode, PIP you set around 16 to 20, PWP 4 to 6, TI 0.45 second, frequency 40, flow 8 to 10 liter if you adjust the flow manually. But if it is automatic adjusted flow, then you don't have to set FIO to 30%. As a primary mode maximum you can go up to 25, PWP maximum you can go 6 to 8, MAP you can go less than 1 kg 1 kg 14, less than more than 1 kg 16. As a secondary mode, initially, whatever PIP you have set, you can go 2 to 4 centimeter. That was on the conventional ventilator. If the baby is on mechanical ventilation convention, PWP 4 to 6.45, the rest of the things are same. And FI to 5% that required on the conventional ventilator. If there is a recurrent apnea, then you have to set PIP on the lower side, like 4 to 16, 14 to 16, PWP 5. That means you have to set the breath just like a normal frequency, because baby's only problem is baby forgets to breathe. In that case, whatever is the normal breath that you have to set. So only thing is that whenever you are using NIPBB and it is non-synchronous, there will be a lot of pressure loss. So that pressure loss you can see by seeing the graphics. Next slide, please. So in the winning, you have to reduce PIP by 1 to 2 centimeter till it is 12 to 14. Lower the breath by 2 to 4 by every minute till the rate of 40 to 80 breaths per minute, and decrease FiO2 by 5% till it is less than. So you would have to consider winning to nasal CPAP or nasal free if the frequency is less than 20. That means you are allowing the baby to breathe. PIP less than 12, PWP less than 4 to 5 centimeter, FiO2 less than 30%, and flow 8 to 10. One important thing you should remember, when you are using a ventilator where you have to adjust the flow manually, always try to keep the flow as minimum as possible, maybe more than 5 liter or 6 liter, not 8 to 10 liters. Suppose we have said initially with 8 to 10 liters or 12 liters, but after some time we have seen that even with 6 liter the same amount of pressure is delivered. That time we have to reduce the pressure flow. Another important message for all of you, that whenever you are ventilating a baby, whatever mode of ventilation you are use, always to try to keep the respiratory support as minimum as possible. Because why? When the patient is taking a negative spontaneous breathing, patient creates a negative pressure, and during the time of negative pressure there is a venous return. But when you are giving positive pressure ventilation, whether it is CPAP or NIPBB or invasive ventilation, you are giving positive pressure ventilation. That's why there is hyperinflation of the lung. When there is hyperinflation of the lung, there will be some amount of decreased venous return, and that will reduce the blood pressure. That's why there is a dictum, whenever you whenever so you always try to keep the pressure as minimum as possible. Next slide. So when you what you will say NAP failure, less than 7.5 PAs, PSO2 more than 16, NNC experiencing more than 4 apnea episode per hour, necessitating tactile stimulation or more than 2 percent of requiring diagnosed ventilation, frequent desaturation, moderate to severe retraction under highest peak of setting of 8. That means not only NIPV, the same thing we see in invasive mechanical ventilation. Next. So now tell me, do you think there is an increased risk of heat intolerance or abdominal distension during the use of non-synchronous NIPV? EPS significantly increase the risk. No mild increase it. Not noticeable. Not noticeable. No noticeable increase in the risk. Bushra is telling this. Good. So next. Okay. So when is saying yes, mild increases risk. They're going to be saying 2. Okay. And he's saying Anshu is telling 2. Right. No noticeable increase in risk. As far the physiology is concerned, you all of you are correct because because most of the time we use non-synchronous NAPV. Sometimes what might happen, and as I have already told you, 30% breath will be synchronized, rest of the breath will be non-synchronous. That means when the baby is having closed bodies, that time ventilator is delivering a breath, and that breath will go to the stomach. So that will have gastric distension. But if you carefully use the ventilator, this can be minimized or this can be managed. Next slide, please. So what we have to do, we have to put a positive. One practical tips. Whether it is a preterm, term, it doesn't matter. When you are giving CPAP or NAPV, put a 8 size tube. And you can keep the tube hanging like this so that the whatever air is there, that can be expelled out. Another tip is that suppose there are a lot of air going inside the stomach. So what you can ask the sister, before each feed, sister can evacuate the stomach. That will help. So third tip is that to reduce the feed intolerance, you can keep the baby in prone position. So that will help for to manage abdominal distension. So there may be abdominal distension, but that is not an issue if you can carefully manage it. One is put a 8 size OG tube, put a plunger in the OG tube and keep it hanging like this. Third is you can keep the baby in prone position. Next slide, please. So cases. Let me discuss some cases. So a 30-week infant, 11-week female with high emergency resuscitation due to worsening preeclampsia. Initial resuscitation involved positive pressure ventilation with the TPs. The Apgar score was 5 and 8 at 1 and 5 minutes respectively. What is the next step? Next step in respiratory support in ICU. Start on CPAP, start on NIPV, intubate, ventilate, observe with oxygen and supplementation. Uh, yeah. So please write in the chat box. Start on NIPV. Kazim is right. Let's start on CPAP. Okay. Dev Kumar is writing. Start on NIPV. Rajkumar is saying NIPV. Anshu is saying CPAP. Okay. Next. So I think there is a mixed response from the audience. Somebody is writing they don't CPAP and someone writing NIPV. All of you are correct actually. See, if you have got a ventilator, you have got the support staff, everything is available, then you can provide NIPV. Definitely in my unit, I will go for NIPV. But if you do not have a machine ventilator, definitely you can start with CPAP. But again, I tell you, whether you start CPAP or NIPV, baby should be hemodynamically stable and spontaneously breathing. If the baby is not spontaneously breathing or hemodynamically not stable, never start any kind of non-invasive respiratory support. Next slide, please. Good. The patient was started on NIPEB and PIP was 18 centimeter water pressure. PWP was 5 centimeter. Rate was 40, FiO2 45%. Within 40 minutes, her workout breathing worsened. FiO2 increased to zero point 0.5. Initial CSTX was suggestive of severe IDS. Venous blood test showing pH 7.22, CO2 58, minus 6.5. What we will do? Increase the NIPBB, administer surfactant by Lisa, switch to intubation and mechanical ventilation. Okay. So we want to deliver surfactant. Why you want to deliver surfactant? Can you write what? Why you are severe ideas? Okay, good. Increase workout breathing. Okay. Anything with FiO2? Because one of the indication of surfactant is that FiO2 increase FiO2 more than 30%. Very good. Excellent. More than 30%. Okay. So another lesson from the case is that any baby with severe RDS, RDS, even mild or moderate RDS, with FiO2 requirement more than 30%, then you can go to a surfactant administration by Lisa or by Insure technique. Next slide. So surfactant was administered as we have said via Lisa. FiO2 decreased to 0.25 and BBG improved 7.32 and basics was minus 3.5. However, after 5 hours, Later, worker breathing worsened and FiO2 increased to zero point 0.4. BBG was this, XS was hazy opposite with lung expansion to 8 trips. What should be the next intervention? Increase the NIBB setting, administer a second dose of surfactant, switch to intubation and mechanical ventilation, monitor with no change in the second dose of surfactant. Okay, second dose of surfactant. Okay, so because baby is almost 6 hours and if I have to requirement almost 40%, that's why you are interested to give the second dose of surfactant. Next slide, please. Good. PIP actually it is not like that. Then go to the next last slide. Go to the last slide. See the uh, PEEP was 5 centimeter. PIP was 15. You can there is a scope of increasing the PIP and PWP because our main aim is to increase the mean area pressure. If you want to increase the mean area pressure, actually either you can increase the PIP or PWP. Next slide. No, no, previous slide. Uh, previous. Increase the next. The continuous you are tapering some. Okay, next. The baby was increased to PIP was increased to 22 centimeter over the next few hours. Workout breathing improved. If I have to decrease to zero point 0.3, PIP was gradually decreased to 20 centimeter next 24 hours. At this state, what should the next step? Continuous NIV support or tapering of support or win to CPAP? Tell continue NIPUB. Okay, win to CPAP. Uh, One important thing is that it is better to switch to CPAP as early as possible because in NIBB most of the time we are using non-synchronous. So the abdominal distension, all these things will be more in case of NIBB than CPAP. So you can switch to CPAP also because baby is stable 24 hours. That is the practice what is in our place. Suppose a baby is presenting with some respiratory distress, baby is on NIBB, we try to switch to CPAP as early as possible. Next. Patient would want to CPAP or 5 centimeter water pressure FiO 2.25 after 30 hours of stability of NIBB. The setting prior to switching to CPAP were PIP 15, PWP 5 and rate of 20 FiO 25. She remained stable and was transitioned to nasal high flow after 10 days and supplemental oxygen was discontinued at 34 weeks of gestation. What does this case highlight? Importance of timely surfactant administration and NIB was an effective mode of respiratory support. But having said this, even you do not have NIPV machine, you can start with the CPAP also because CPAP is standard of care till now. Next. So the another is BiPAP. BiPAP is was actually commonly used during the time of COVID. BiPAP means it delivers two level of CPAP, one higher and one lower. Next slide. So it can be delivered mostly by the ventilator and by flow driver. And always one important thing is that it mimics timing and setting of ventricular intubation. The problem is that in BiPAP the maximum minimum pressure difference should be less than 3 to 4 centimeter and delta pressure here more than 5 centimeter. And in BiPAP the respiratory rate is very low, 10 to 30 per minute. And in case of NIPB you can keep the like a normal ventilator. So, but mostly in BiPAP we are not using in our clinical practice. We are using NIPB only. So I will not discuss more on BiPAP. Next slide. Leave it. Next slide. Next slide. Next slide. So what we have learned, NIPB is better than CPAP, both as a primary mode and secondary mode. So you have got the facility for NIPB, you can use non-synchronous NIPB, and some of the practical things we have discussed. So NAVA means there is a prominent newer diaphragm triggered respiratory support. NAVA synchronizes respiratory support by electrical activity of diaphragm, what we have said. Shown ED signal, NAVA provides rapid response time and excellent ventilator synchrony. Next slide, please. So in the NAVA, there is contraction of the diaphragm. So there is a tonic contraction of diaphragm. There will be some electrical changes of the diaphragm. Normally, what happens when there is a contraction of the muscle, there is electrical activity. So that electrical activity is actually recognized by the ventilator, and ventilator delivers a breath. I am not going into details of NAVA because most of you will be not using NAVA, but just remember the basic principle of NAVA. When there is diaphragmatic contraction, there will be change in the electrical activity. That electrical activity is called electrical activity of diaphragm, and the tonic activity, and there will be tonic activity of diaphragm during expiration. So peak inspiration and expiration. So that difference actually is very important. So what this machine does, this machine calculates ED max and ED mean, and and there is a NAVA level. The NAVA level is an arbitrary number that is set by in the machine, and this ED signal is recognized by the machine, and this ED signal maximum minus minimum microvolt changes is multiplied by NAVA level. That much of pressure is delivered to the baby. That means PIP is equal to PWP plus NAVA level into ED max minus ED minimum. That means in NAVA, what happens? PIP is decided by the machine based on the maximum electrical activity of the diaphragm and minimum electrical activity of the diaphragm and the NAVA level. And the threshold triggered is there 0.5 microvolt. So this is the physiological principle of NAVA. It actually detects the electrical activity of the diaphragm, and based on the electrical activity of diaphragm, it delivers PIP. Next slide, please. So this is Nava, what you have seen. This is the catheter. This is the catheter. One end of the catheter will go to the ventilator, and other way you can feed the baby. So these are the parameter you set. You set Nava level, you set ED maximum, ED minimum, and ED trigger, and the respiratory rate. See, you see there is good synchronization here. So, but the problem of the NAVA is that it is partially invasive because you have to put a ED catheter, and it is disposable. It costs around 15,000. Only one machine actually they are marketing this. This is Servo, and NAVA can be used both invasive as well as non-invasive way. Next slide, please. I think skip this slide. Next slide. Next slide. So we will now discuss nasal high frequency ventilation. So in NIBV, what we saw, ventilator is delivering a pressure on the top of CPAP. So that increases the mean air pressure. With nasal high frequency ventilation, what it happens, there is high frequency pressure changes are added to the any device to provide high frequency modulation to flow. This modulation can be oscillatory, interrupted, or pulsatile design. Subphysiological tidal volume and supraphysiological rate. Next. Next slide. So advantage of nasal high frequency is that on the top of CPAP you are giving some oscillation. That is the advantage. In case of NIPP, what we give on the top of CPAP, we are giving some inflation. Here on the top of CPAP, we are giving some oscillation. So here you can get all the effects of invasive high frequency oscillation ventilation by putting a mask or prong. That means in nasal high frequency oscillation ventilation, there you are giving some oscillation on the top of CPAP. So these are oxygenation can be improved by increasing the mean air pressure and FiO2, and ventilation can be improved by amplitude and frequency. Anindra, please. So you see this is the oscillation. This is the mean air pressure. So there is the oscillation on the top of the CPAP. Next. Next. So this baby is on nasal high frequency oscillation ventilation. I think we have seen here. Can you start the video? See. So baby is breathing. This is oscillation going on. So what we have seen in our clinical practice, initially we try with nasal non-invasive positive pressure ventilation. But if the patient fails in NIPV, before going to invasive mechanical ventilation, we can try with nasal high frequency oscillation. We have seen many babies, mechanical ventilation can be avoided by connecting the baby with nasal high frequency oscillation ventilation. That's why I see, say, in between NIPV and invasive mechanical ventilation, nasal high frequency oscillation ventilation may be there. Next slide. So what are the things we have to set in nasal high frequency oscillation ventilation? Set map 3 to 5 centimeter above map on APUV. Amplitude roughly twice the mean air pressure, frequency 8 to 12, I ratio 1:1, or 33 to 50% of the respiratory cycle. So for post extubation we use, and when FiO2 is less than 0.3 and MIP around 6 centimeter, we can go into NIPV. Post extubation we can use 8 to 10, delta P 25 to 37 frequency. Next slide, please. So what are the evidence? So we did a randomized control. The evidence says that There are a lot of next slide, please. So it reduces the failure rate and it improves CO2 level. Next slide. So there is a meta-analysis shows that it can reduce the reintubation rate. That means there is 32% reduction. Next slide. I think we can skip this slide. Next slide. Next slide. So we did a study. One group of babies was given nasal IPV, that non-synchronous. Another group was given nasal high frequency oscillation ventilation, and our primary outcome was extubation failure. We found that there was not much statistically significant difference between the reintubation rate between the nasal high frequency group or nasal IPV group is, as you have seen here, 9.3% versus 11.6%. But although there was no statistically significant difference, but there was clinical significance because it was 9.3% and it was 11.6%. Now also what we are doing, any baby who are failing on nasal IPV, so before going to invasive mechanical ventilation, we try with nasal high frequency oscillation ventilation, and many babies can be saved. Next slide, please. So, what is the message for all of you? Us. CPAP is the still standard of care. NIPV is one of the most important effective mode of NIPV for respiratory support for preterm infant. Nasal ventilation is a bridge between CPAP and invasive ventilation. NIPV is better than CPAP both as a primary mode and secondary mode, provided we have got a ventilator. One should try NIPV as a primary mode if there is availability of ventilator, which may not be possible in many centers. Nasal high frequency oscillation ventilator is another bridge between NIPV and IMV. Synchronization is an issue in NIPV. However, evidence suggests there is not much difference with non-synchronous NIPV, and our clinical practice shows that in the last 5 years we have ventilated not more than 500, less than 500 infants on non-synchronous NIPV, but hardly we found any problem. So effective synchronization is only possible with NIV NAVA, but this is costly. Clinicians should make every effort to avoid mechanical ventilation. Thank you very much. Thank you for your patient hearing. If you have got any questions or query, next slide. So this is Professor Alan Job. He says mechanical ventilation in the newborn is a necessary evil. We do it because we must, not because it is good. Thank you. So if you have got any question, setting up nasal apparatus, how to adjust. See, very good question. See, what you have to do normally when you use uh, invasive high frequency oscillation ventilation, you see the wiggle or up to the umbilicus. But in case of NIP, nasal high frequency oscillation ventilation, you can see vibration up to the neck, that may be applicable. And second is amplitude.
Please stop sharing.
So, so that is it. So amplitude means if you can see vibration up to neck, that may be enough. Second is amplitude. Amplitude is based on the whatever map you set, you just make it double. Suppose map is set around 11, amplitude will be 22. Third is the MAP. MAP is based on your FiO2. Second important thing here, setting here also, you have to do a X-ray. You see the X-ray. Based on the X-ray, you can adjust your MAP. MAP should be adjusted based on your saturation as well as X-ray. Another important thing, there is a term called lung recruitment strategy. So if the baby is having RDS, what you can do, you can increase the MAP and see at what MAP baby saturation is stable. So that is the height, and beyond that there will be low saturation. So that is the highest infusion pressure. Then you gradually decrease the MAP and come to a level and see at what one baby there is, at what decrease MAP the saturation is stable. That is a lower inflection point. You can keep that. That you can practice. That we are doing sometimes. So if the baby is having RDS or something. Sedation sedation should be avoided in any case of in most of the in all cases of non-invasive positive pressure ventilation, because what I have told you, in non-invasive ventilation we have to select a baby who is spontaneously breathing and hemodynamically stable. If you give sedation, it may cause depression of the respiratory drive, and that will not be good for us. Next slide. Any questions?
Please,
You can
unmute. You please unmute and ask the question if necessary. Please
you can unmute and you can ask me.
Please, dear participants, please unmute and ask question to our neonatology expert and the man behind our ventilation workshop. Please ask. If there is any doubt,
Hello. So, if there is no questions, some of the things that let me tell you. Prescription number one: non-invasive ventilation should be applied for infants who are spontaneously breathing and hemodynamically stable. That means heart rate should be more than 100, baby's color should be good, blood pressure should be normal, no mottling, etc. Next important thing: if the baby is having central time of apnea, like baby with severe perinatal asphyxia, it is better not to use non-invasive positive pressure ventilation. That baby will fail. Third, you can use any ventilator for non-invasive positive pressure ventilation, but you have to see
अरे देखो
how do you know that your pressure is optimum or your flow is optimum? Because there will be a lot of leak in non-invasive positive pressure ventilation. You have to see your PIP in the ventilator screen. Whatever PIP you have set, the same TIP is delivered in the ventilator screen. That means your flow is adequate. If you are using a machine where you can manipulate flow, you can manually adjust the flow based on the PIP what is shown in the graphics. Second important thing is the synchronization is good, but most of the machines what we are having, they cannot provide good synchronization because of the inherent problem. So, so Rajkumar is telling if the baby is restless and fighting, what to do? Good question. Rajkumar, let me tell you, when the baby is hypoxic or the alveoli is not recruited, baby will be restless because of hypoxia. As I have already told you, the main aim of ventilation is that the some of the alveoli will be collapsed completely, both during inspiration and expiration. Some alveoli will be collapsed during expiration, but inspiration alveoli will be open. Both are bad. But what happens in a normal spontaneously breathing infant? Alveoli will open during inspiration, and during expiration it will not be totally closed because of FRC. So in case of totally collapsed alveoli, you have to open the alveoli and keep it open. So if the baby is restless, that means your ventilation is inadequate. So if the baby is having tachypneic or there is lot of retraction, you increase the PWP, and also you can increase the PIP. If you see that after increasing the PIP or PWP, and you have to closely observe the baby every 15 to 20 minutes, seeing the retraction, workout with the saturation, Silverman score, etc. So by that you have to increase or decrease the settings. So once the baby is getting adequate ventilation, that means alveoli are open, and most of the alveoli, all the alveoli are participating in gas exchange. That time baby's hypoxia will go. When the baby hypoxia is over, baby will gradually settle down. So initial 30 to 40 minutes or 1 hour may be challenging, and that you should be very careful. Second important thing, whatever ventilation you are giving, you see whether the baby is getting or not, because many a times there will be lot of leak. When there is lot of leak, actually if you see I have given a pressure of 20, many times you will see that it will just give a pressure of 5 or 10. That means there is lot of leak. That you should very be careful. In the NIBV, that is the main concern, and that is why another important saying is that keeping a baby on non-invasive respiratory support is more difficult than keeping a baby on invasive mechanical ventilator, because there is a tube. So your monitoring should be good, your nursing staff should be good. You can't just connect a baby with non-invasive positive pressure ventilation and go out. I think I could answer your questions. Anything? Even in CPAP, baby will be restless. So, but after half an hour, 1 hour, the restless will go. Any more question?
question, we can
In
close the session.
No, sir, there is a question. In case of leak, what is the maximum PIP flow up to which we can increase up to required PIP? See, whatever PIP you set, if the PIP is not delivered, that means baby is not getting anything. So even the automatic adjusted flow, that now we can say how much PIP you can go. That depends on the pressure. Suppose you have set a pressure of 20, but the delivered pressure is 10. That means 50%. There is 50% leak. So what will happens? You have to increase the maximum PIP we suggest do not go more than 12. Rather, you can see the interface, whether the interface is fixed properly or not. Many times your interface will be loose. If there is loosening interface, then there will be a lot of leak. So you can go in case of manually adjusted ventilator, you can go up to 12. But when if you use a automatic adjusted flow parameter in some machine like VN600 Servo N, there you don't have to think. The ventilator will do your job. Ventilator will automatically adjust. Is there any minimal initial settings in NIP? That we have told you. Initially, so, we will discuss on the mechanical ventilation. PIP should be minimum 12. Why 12? Because when a baby takes a spontaneous breath, baby creates a minus 6 centimeter pressure. And when you are giving a circuit for circuit, another 6 centimeter. So it should not be less than 12 centimeter. But if, having said this, in case of NIP, there may be some kind of leak. So you can give 15 or 16 like that. Second is PEEP. Physiological PEEP is 4. But so it should not be less than 4. That's the minimum PWP. Then FIO2 you can start with 30. Then the flow. Flow you can start with 6 or 8 liter, and based on the PIP delivery, you can increase or decrease the flow. Next is TI. TI you can start zero point 0.4 or zero point 0.5 like that. So these are the initial setting in most of them, even in invasive ventilator also. Only problem with in invasive ventilation, whatever pressure you give, that will be delivered because leak will be minimum. I think I could answer your questions. Next, any more question? Another thing,
No.
some of you were asking for slide and everything. See, that will be done at the end of the workshop. First, let us carefully listen to all the talk. I think all the speakers are excellent. So listen to them carefully and note it down. And whatever you doubt, you can ask us. There will be no issue. I think with all this, if there is no more questions, we can wind up today. Thank you very much, and very sorry that there was some technical problem in my laptop that created some noise in the non-synchronization was there. So sorry for that. Thank you very much. I think next
Thank
talk will be on tomorrow or day
tomorrow.
after tomorrow. Tomorrow.
No, no, 25. On
Yes,
25th.
25th, sir. Tomorrow.
Ah,
Tomorrow.
talk is on the tomorrow.
Tomorrow. Thank you very much. Thank you, sir.
Thank you,
Uh,
thank you, thank you,
Thank you, sir.
everybody. Yeah.
And if there is no question, we can wind up. Thank you, Anindo, for
Thank you, sir.
Yes,
helping me. Thank you.
Thank you,
yes,
sir.
yes, yes.
Uh,
Thank you,
thank,
everybody. Good night, good night,
good night. Good night, sir.
good night. And thanks to Bijan for the nice deliberation of this topic. Thank
Thank
you,
you, sir.
everybody.
Thank you, sir.
By saying good night,
Good night, sir.
I am closing the session. Thank you
Thank
all.
you, sir. Mm.